Okay, Okay, good evening, everyone. Thank you for taking time to join us for the webinar this evening. My name is Wendy, and I'll be the moderator for today's webinar. Today's webinar topic is on the Musculoskeletal Clinical Translation Framework, and is organized by the Pain Association of Singapore and supported by the Singapore Physiotherapy Association and the Sports Medicine Association of Singapore. Thank you to our colleagues from the Physiotherapy Association and Sports Medicine Association in helping to publicize this webinar and reaching out to more healthcare professionals. We hope you'll enjoy the learning this evening. Now, these are the speakers this evening. So we have invited Dr. Tim Mitchell, who is the lead author of an internationally recognized ebook and app named Musculoskeletal Clinical Translation Framework, From Knowing to Doing. The ebook has been downloaded in over 50 countries and is now used in healthcare education programs worldwide. Thus far, the ebook has been translated into 4 languages and is recognized as a practical tool to enable delivery of contemporary care for people with musculoskeletal pain. A little background about Tim. So Tim is a specialist musculoskeletal physiotherapist as awarded by the Australian College of Physiotherapists and has his own private practice in Perth. He has completed a PhD in the area of low back pain and has a special interest in the translation of logical reasoning into clinical practice. He's also a senior academic at Curtin University in Perth, Western Australia, involved in the clinical education of physiotherapists and clinical research. How I got to know the brilliant Tim? So he's a part of my PhD supervisory committee. On behalf of the Pain Association of Singapore, Tim, thank you very much for accepting the invite very promptly to present today's webinar.
No problem. Thanks for inviting me, Wendy.
Okay, next, we have local co-speakers joining us today as well. Dr. Ong Say Yang is a consultant anesthesiologist at the National University Hospital and a pain service lead at Alexandra Hospital. Dr. Yang Su-Yin is a principal psychologist specializing in chronic pain management. She leads research projects at Pain Management Clinic at Tan Tock Seng Hospital and also holds a content expert and clinical facilitator position at Lee Kong Chian School of Medicine. Say Yang is the current president of the Pain Association, and both Su-Yin and myself are council members. Together, using a multidisciplinary approach, the 3 of us will present 2 local vignettes and join Tim in discussion to show you the application of the framework and help you understand your patient's pain presentation more holistically. So this is the timetable of today's event. First, Tim will introduce you to the Musculoskeletal Clinical Translation Framework, followed by the local co-speakers will present on a case study, a patient with chronic low back pain. How to make sense of the pain presentation using the framework will then be discussed, followed by a Zoom poll and question and answer session. In the later part of the webinar, the local co-speakers will present on a second case study, a patient with knee pain, followed by the application of the framework, and then another Zoom poll and question and answer session. Now, please note, participants will be muted during the webinar. Please feel free to post your questions at any time during the webinar using the Q&A function in this Zoom platform, and we'll address the questions during the Q&A session. Now, in the event that there are too many questions and limited time, we seek your understanding that we may select and choose questions to be answering, and you may follow up with us on email. Should you wish to clarify your questions with any of the speakers, please use the raise hand function on Zoom and we'll reach out to you. This webinar is being recorded, and all case studies cited in this webinar are designed in part fictional and in part real. So this is done for the purpose of creating the 2 vignettes specific and relevant to the Singapore healthcare context. All our speakers today have no conflict of interest to declare. So without further ado, let me pass it over to Tim to introduce the framework to you. Tim, please. Tim, I think you are muted.
Thanks, Wendy. Are we good now?
Yep.
All right, this first part, hi to everyone, and particularly hello to people that I've met before or have been involved in any of the programs down at Curtin University or other teaching involved in Singapore. So some of you may be familiar with the framework, others not. So this is just a quick covering off, if you like, of the main aspects of the framework. And as you can see of the graphic there on the right, it's quite, well, there's a lot of evidence now around the biopsychosocial model for managing musculoskeletal pain. And there's a range of models of care and clinical practice guidelines around that, but translating that to the patient in front of you is not always that straightforward. And that's how the framework came to be developed, to fill that gap where you have a specific patient in front of you and I know what I should be doing and I know the theory, but how does it work with this particular person? And dealing with people with pain is difficult. It's not a matter of here's the broken bone, this is the treatment that's required to fix it. There's a whole range of those different biopsychosocial factors that can contribute, but each person's pain experience is quite individual. So using a couple of cases today should be quite helpful to outline that. Now, to start with, we'll just talk about the different elements of the framework. And we have the individual's perspective as the start of the framework, most importantly, because it is about that individual person and their perspective on their pain or the symptoms that they present with. So there's a range of questions listed there that we may ask the person that we're doing a consultation with to help us get an understanding from their perspective of what the problem is, and also how it more broadly affects them in different aspects of their life. And importantly, we don't ask the question, where is your pain? Because for some people, pain isn't the main concern. It may be sleep, or it may be impacts on different other elements of their life. So keeping that broad, open-ended question at the start of the consultation can be particularly helpful. So you'll see on the bottom right there are the different elements of the framework, and I'll just quickly talk through these now. So diagnosis, you'll all be familiar with internationally accepted diagnostic triage of looking for red flag disorders screening first, and then if it's clear for that, looking at does this person have a specific diagnosis or a non-specific diagnosis. And the questions on the bottom left are a useful context to think of what happened at the onset of this person's symptoms. So in the presence of trauma, clearly considerations around specific diagnoses such as fracture, for example, would be quite important. Similarly, if there's a repetitive use or overload history, then there may be some specific tissue overload that fits with that story. But usually more than 50% of the people we'll see will describe an insidious onset of their symptoms. And that becomes important to consider red flag disorders. But it may also be equally important to consider what combinations of factors combined to make this person's system either pre-sensitized or susceptible to the onset of pain or other symptoms. The stage of the disorder is fairly self-explanatory, but it's important to remember that's not just a linear time progression, because we call some people with their presentation saying they have an acute presentation. And it might be acute because it's only just started, but in the absence of tissue injury, our management for that acute presentation may differ from, say, an acute ankle or knee sprain or a fracture, for example, because if there is no tissue injury, we don't need that initial rest, ice, protect, elevate, for example. And chronic is also important to consider, because truly the diagnosis should be pain that extends beyond the expected period of healing, because some people may have underlying health conditions such as diabetes that delay expected healing. So they might be 3 or 4 months into the onset of their symptoms, but you wouldn't say that they've got a chronic pain problem at that stage, because there may still be underlying tissue healing required as part of their recovery process, even though it is later on in the disorder. Now, the pain features is the complex one that often challenges people the most. And you'll see there on the panels, on the left is the types of pain, and they're the IASP internationally recognized different pain types. In the middle part is more a clinical distinction around the behavior of someone's symptoms being mechanical, a mixture, or more non-mechanical. And that's really useful when we're discussing what factors are either aggravating or easing someone's symptoms, for example, to judge the behavior of that. Now, non-mechanical symptom behavior might be in the presence of someone with inflammatory type pain, because that's more of a constant type symptom presentation, we're also in more widespread non-specific disorders as well. So it's a clinical, useful consideration in terms of the characteristics of their pain. And sensitization on the right, I'm sure you're familiar with central and peripheral sensitization, but in terms of clinical meaningfulness, broadly using that term sensitization and understanding that there's further amplification or dysregulation of the nervous system can be really helpful for us considering what might be the main drivers of some people's presentations. Now, these different panels are really helpful to list. Let's think about these different factors that might be relevant or might not for each individual. And you'll see on the left, the psychosocial is the cognitive, which is the thoughts and beliefs, the affective, which is the mood, and the social, which is obviously people's social environment, their home and living situation and other personal factors. And we try and rank each of those in terms of their contribution to the person in front of us as low, medium or high. And you keep in mind, some people might have significant mood issues, but it may be an underlying issue for them and irrelevant to a presentation such as an acute ankle sprain. Whereas in other instances, mood may be the main driver or the main barrier for this person not being able to recover. And then we'll consider lifestyle considerations such as sleep and exercise levels, because we know there's good research around those factors contributing to either pain sensitivity or recovery from a range of different health conditions. And then also taking a broader picture of the person, so the whole person considerations. So that might include their general health and other comorbidities such as diabetes, like I mentioned, which can be a factor that will delay tissue healing, for example. Then, of course, workplace considerations become very important. For some people, that is the dominant issue, and work for most of us is a really important aspect of our life, and we spend a lot of time there. So both our perceptions around work and specific workplace factors may be issues relevant to the onset or the maintenance of someone's pain experience. So I've just put here this concept of a person presenting being pre-sensitized, or perhaps maybe the reasons why pain persists after we've expected that the normal time for tissue healing has occurred. Now, in the pre-sensitized example, you might have someone that presents with low back and leg pain at the end of a work shift, but there was no specific incident or no story of overload that was a clear reason as to why their back pain and leg pain commenced. So then we have to consider, are any of these other elements present, such as high levels of distress, really poor sleep, or lower general health that perhaps pre-sensitizes the nervous system for the onset of pain, which would then shift us away from focusing on pathology and more a broader approach once we'd excluded pathology with an appropriate assessment and examination, of course. And then also for someone with long-standing widespread pain, these factors might be some of the reasons contributing to why pain persists and their system isn't settling down. And that same concept may apply even with someone with an acute knee injury from a trauma. Then healing should occur in the expected timeframes. If it hasn't, what else is contributing to that? Is there missed or associated pathology, or are these other factors more important as time goes on? Now, the functional behaviours is really helping us think about how this person is moving and functioning, and shifting us away from just looking at a whole range of physical examination tests. On the left is the help value. So in terms of how this person is moving or functioning, is it helpful or unhelpful considering their presentation? So in the top picture, in the case of an acute knee sprain, if someone's limping, that's probably quite appropriate and helpful to protect those tissues that they've just injured. On the bottom picture there, if someone has right-sided low back pain and referred symptoms down their leg, and they're loading and leaning over to the right side, which is contributing to a compressive radiculopathy, then their functional behaviours are probably unhelpful because they're contributing to the either development or maintenance of their symptoms. Then on the right side, we consider a range of different behaviours. So are there impairments of movement, impairments of how they're moving? Are there a range of pain behaviours, or is there broader deconditioning presenting to their physical presentation? And that really helps us guide what should the focus of our management be, and we'll cover that in those case studies. So once we put all that picture together, and I'll show you an example in a minute, we're really trying to come down to be able to help the person in front of us, give them information around what's wrong, So a diagnosis, but what's wrong and what's caused that. So making sense of their story. Then what other factors are contributing either to the symptoms starting or why the symptoms aren't recovering. And then we make a plan out of that. So what needs to be addressed, particularly focusing on what's modifiable, and obviously in order of priority, because often we can come up with a lot of options, but which ones are going to give us the best bang for our buck or most likely to help this person out? And who needs to be involved? Do we need a team of healthcare practitioners involved in this, or is it something more straightforward? And agreeing around timeframes to review and measure to check the management we're implementing is on track and helping that person move forward. So we'll just show you here, this is the main sort of front page or the main figure of the framework, if you like. So you may have someone with persistent back pain, for example, that fits with a non-specific diagnosis and it's a chronic persistent problem, but their symptoms might be nociceptive pain, but their presentation is such that there's non-mechanical characteristics to their pain. So they're constantly sore, lots of things aggravate them, few things ease them, and it doesn't take very much activity and they might be flared up for the rest of the day. And that leads on to the next panel there, indicating that their sensitization is high. So there's a lack of correlation there between the stimulus and the effect. So doing a small amount of activity might flare them up for a few days, for example. Then in this case, for example, their beliefs about their problem might be unhelpful. There might be significant mood issues and there might be challenges at home, such as they've got young children to look after or an unwell family member to look after that could be contributing. Work might be an issue because it's highly physically demanding for them. There may be some lifestyle issues around their sleep or lack of exercise, perhaps, and there may be other factors around them, perhaps being generally unwell. So then we'd have to go, right, of all those factors, which of those do we put together to help this person recover? And there might be a range of physical examination findings. So that gives you a snapshot of what the framework might look like. It can get very involved or it can get very simple. And obviously you might see someone the first time and then how their presentation looks at later timeframes will change. So this is a quite fluid process depending on what management is implemented and how they respond to that. So now if we look at some cases, then that will hopefully help clarify this in specific examples. Now, I'll just hand back control to Wendy.
Thank you, Tim, for the very succinct introduction to the framework. So now let us jump right into our first case vignette. So this is about someone with low back pain. So if my spine has degenerated since young, I need to protect it. So this patient has very protective behaviors. So this is Mr. Shanker. He's a 40-year-old gentleman, slightly obese. BMI is about 30. And he has had debilitating low back pain for the last 10 years and it's affecting him both in terms of his work and his lifestyle. So his pain is described in the low back region. Pains he experiences an average numerical rating scale of about 7 to 10 in terms of pain score. He describes his pain as constant and achy, and at times it will radiate down both his gluteal regions up to the posterior thighs. Other relevant medical history for Mr. Shanker: he's a smoker, and in his adolescence was diagnosed with mild idiopathic scoliosis. But the main thing that's troubling him is this chronic low back pain. And the trigger event was actually a work injury when he was attempting to bend and lift a heavy carton of crabs about 10 years ago. And since then, you can see from the slide that he has sought medical help multiple times. So he was offered, he had a magnetic resonance imaging of his spine and was told that the lumbar 5 vertebral body was slipping forward due to a past defect. And ever since then, he has sought multiple treatments from complementary to Western medicine. So he has gone for acupuncture, he has tried traditional Chinese medicine, massage, but none of them seems to have brought him long-term relief. About 9 years ago, he underwent a bilateral lumbar 5 pass injection with some relief. And then thereafter, he saw an orthopedic surgeon and underwent a lumbar 4 to sacral 1 decompression and spinal fusion surgery for his spondylolisthesis. Even after the surgery, he continued to suffer from pain. So he saw a pain physician and he underwent 2 rounds of lumbar facet blocks with a radio frequency ablation of those facet joints. But unfortunately, low back pain still continues to affect him. So when we examined Mr. Schenker, his gait was normal. He was able to walk unaided, but in terms of his range of motion, there was some limitation due to pain. He couldn't extend or flex his lumbar spine fully, and he had trouble doing lateral bending as well. His paraspinal areas were fairly tender, and there were some spasms, and it was approximately around the level of lumbar 3 to lumbar 5. Neurological examination was generally normal, but however, we were not able to perform provocation tests such as the straight leg raise and the Faber's test because of pain and fear of movement. So when Mr. Schenker saw us, he already had a couple of imaging investigation. He had a lumbar spine X-ray that didn't show any fractures or dislocation, and his spinal implants were not displaced. An earlier MRI lumbar spine did show some mild lumbar facet arthropathy and also a lumbar fusion. His lumbar fusion implants from lumbar 4 to sacral 1. There were no significant spinal stenosis or neuroforaminal stenosis. So in terms of medication, Mr. Schenker is using Anorex, 2 tablets 3 times a day. He's on an antineuropathic medication, pregabalin 75 milligrams twice a day. And for his pain flares, he's using tramadol up to 3 times a day. And on the average, he uses about 50 to 60 tablets a month. So that's about 1 to twice a day.
Okay, so when asked about his aggravating factors, Mr. Schenker pointed out that standing for more than 20 minutes will give him pain, and bending forward will give pain immediately. Okay, so when the physio observed his posture in static standing, he appears to be standing with a lot of active extension of the lower back. And when asked why did he do so, Mr. Schenker said that he's really afraid that his posture is not straight or upright enough, and he perceived that if he slouched, that will cause his condition to be worse. So when asked to demonstrate how he bent forward, he guarded his back, just like shown in this picture here, okay? And took a deep breath, braced his core muscles to reach forward. So there's hardly any spinal flexion movement, not just on the fused lower lumbar segments, but he mainly executed that forward bending movement with an extended back and mainly with hip flexion. Now, he stated that his relieving factors are rest, but quickly admitted that it was not possible due to his current lifestyle and work. The use of a lumbar corset helps, as well as medicating on tramadol helps. His 24 hours pain behavior, so there's back stiffness, which resolves approximately in about half an hour once he gets out of his home to work. The pain increases throughout the workday, and the most pain is experienced prior to sleep. He also complains of disrupted sleep and wakes up in cold sweat, but there are no known triggers. Okay, so current activity levels, he's a rather sedentary guy, okay? He don't do any regular sports, and he volunteers the information that 10 years ago, prior to his back injury, he did recreational running for 5 to 10 kilometers distances with ease. Now, the pain has zapped a lot of energy out of him, and he currently only plays with his son when he has enough energy to do so.
So in terms of the psychosocial aspect, Mr. Schenker lost his job as a restaurant manager in December 2020 during the COVID and pandemic period. His current employment is a food delivery driver, and he's married with a 5-year-old son. He lives in a 3-bedroom HDB public housing with his wife, son, and elderly mother. He's also the sole breadwinner of the family. The mother has partial paralysis from a stroke. In terms of his pain beliefs, Mr. Schenker believes he can't afford to injure himself again. It's better to rest and not to do too much, that he needs to push through and continue working even with pain, And if his spine gives way, he might be paralyzed. And ultimately, he cannot become disabled and burden his wife and son. In terms of his pain behaviors, he used pain medications as a first line of pain relief, like many other patients. He shifts weight from side to side while waiting for food collection. He lies down to rest upon returning home from work. Reduced engagement with son. Physical intimacy with wife is also impacted due to pain. He isolates himself and avoids heavy loads. Mr. Shankar is fatigued, quick-tempered, and apathetic. In terms of his treatment goals, Mr. Shankar hopes to be able to play with his son at least 20 minutes a day, to learn to control his temper, to maintain long-term ability to work, to be able to bend, reach out forward, and he's very keen to return to jogging at least 2 kilometers after 3 months. And now, after our presentation, I'm going to just hand this time back to Tim to walk us through the framework to see how we can apply it to Mr. Shankar's case.
Thanks, Su-Yin. So this, what you're seeing on the screen now, are screenshots from the MSK Pain app. And it just helps to outline the different factors that we've presented or we've heard presented there around Mr. Shankar. You'll see in the diagnosis box, I've actually marked specific diagnosis and non-specific diagnosis. I would probably call this a non-specific diagnosis. Initially, he did have a very specific diagnosis and had a surgical intervention, but he's had enough management directed at that, including his pain procedures, that didn't clearly provide him significant relief, which suggests the local structures that have been addressed there aren't necessarily the source of his symptoms. So at any time here, if Say Yang or Su-Yin want to comment on any of this, happy to have your input, but that's where I'd be approaching this as perhaps what's the dominant presentation. Obviously, he's chronic persistent at this point. The features around his pain, it predominantly sounds like nociceptive pain. There is some referred symptoms to his leg, but it's not in a specific dermatome. So there's not looking like there's clear features, obviously, from what we've had presented so far around if there's sciatic nerve or other sensitivity. But as we've heard, there's some limitation on doing that full examination because of the pain. There's a mixture of mechanical and non-mechanical because there are some aggravating and easing factors described, but the pain is fairly constant and at quite a high level. And the sensitization side of things as well, we'd have to assess that a little bit more, but he talks about things being relatively easily aggravated with limited amounts of activity.
Thank you, Tim. Maybe I'll just jump in a little bit here to contribute. So you're quite right that Mr. Shankar did have some specific diagnosis. I think initially at the start, there was some question. He had been diagnosed with L5 spondylolisthesis, and then perhaps some lower lumbar facet arthropathy that was contributing to his low back pain. But you're quite right that there's been a lot of interventions and surgical treatment directed at these diagnoses, and yet he continues to suffer from low back pain. So it is not uncommon that sometimes we see this in our clinical practice, that we have a patient that comes to us with a long history of pain and with a very biomedically focused mindset, and they've seen a couple of specialists, they've seen a couple of therapists, and they've undergone a whole range of medical interventions, and yet they're still in pain. So you're quite right to say that perhaps now we need to shift our thinking to a non-specific diagnosis, and definitely Mr. Shankar is a highly sensitized individual.
Yeah, thanks for that, Say Yang. And I use that in my consultations with the patient to say, look, the good thing is you had a problem, you've had surgery on it, and that's been followed up, and we can see that the surgery's been successful. You've had other procedures since then that didn't clearly change your symptoms. So that is really helpful for us to now know we need to look at what else is causing your ongoing symptoms. So really bringing the patient on board with that can be quite powerful if we're aware that we need to shift their beliefs. Now, on the next slide, you'll see here, and I'm sure a lot of you were thinking this, and Su-Yin outlined this nicely, There's clearly a range of cognitive factors around the beliefs that are present with Mr. Shankar. There's mood factors there, and he talks about being short-tempered and quite angry quickly. The social factors around his situation at home with his family, and also an elderly parent as well, who's requires some degree of care. So all of those things come into play. We just need to work out with Mr. Shankar how relevant they are and which are the priorities of those. And obviously that can come out in further conversation or in detail at the time. From a physiotherapist perspective, I would have some degree of discussion around those factors and ask his perspective on those, but more specifically, I would explore things around the cognitive factors around his belief about the structure of his back and what is safe or what is unsafe to do. Just continuing on these, and then I'll get Su-Yin to comment. So I'll put the workplace or work considerations as medium here, because he needs to keep working, and that's sort of a concern for him. But it's not the main barrier. If we can get his symptoms better, he'll cope better with work. So we may not need to address that directly, but we'll keep that in mind. Lifestyle considerations are very high, given basically his absence of exercise and his sort of passive approach to trying to manage his symptoms. But the positive is he has that goal of returning to running. So he obviously has some thoughts in there that he's got capacity to get better, which is great. And we'd be using that as sort of one of the goals to build towards. I didn't get any other major general health or other whole person considerations from the information available there, so I've marked that as low. Do you want to comment on any of that from the psychosocial perspective, Su-Yin?
Yeah, so in terms of this case, we try to be very subtle, and I think it's the subtleties that are usually missed out. So if we go back to Mr. Shankar's belief, he really sounds like someone that is pure avoidant, right? But if we think about it, I kind of thought to enjoy myself again, it's better to rest and not to do too much. Really sounds like someone who would avoid doing things or avoid activity. But we look at the next pain belief, I need to push through and continue working even with pain. So this is I thought it would be good to discuss it here, where are we actually looking at a case that he presents himself differently in context, where he presents as an avoidant behavior, but actually he could also be an overdoer at work, because he is the sole breadwinner. So we put things together. He is the sole breadwinner. He has to look after his mom, who has a paralysis from a stroke, and he has a 5-year-old son. So many roles that he's playing, but at the same time, he's also fatigued, he's angry and apathetic. So it's that finding that balance. And I think this is the part about the psychosocial aspect that is really interesting. And it's how do we then actually not miss the subtleties? What are the key points here? Yeah.
Yeah. And I think this is a good case for us to consider those aspects. And you often get those conflicting statements from patients, don't you, where they'll say one thing and then they'll say another thing, and it doesn't quite make sense. As a physiotherapist, we're very fortunate that we can do the physical examination and put hands on and also explore movement with them. So we'll do that a lot, where we'll look at the function and the movement, and Wendy alluded to that in terms of looking at how he was bending. So that would obviously be a clear angle in to start with, to see if we could modify that and change his symptoms. And then through exploring that with him, that becomes an opportunity to perhaps shift some of those beliefs a little bit and get a bit of understanding of how he really is functioning. So that's where I would be approaching this individual case initially, because it sounds like there is an angle in from that functional behaviours perspective. We'll just move on to the next component, which is the functional behaviours. So from what we know, I'm guesstimating, but this would take further physical examination, that his functional behaviours are unhelpful. And what we mean by that, and Wendy said there, he's got effectively a hyperlordotic posture where he's completely avoidant of bending. He tends to breath hold and tense his core muscles. But we can only judge that for certain if we modify that and he gets relief of his symptoms. So if we can encourage him to relax and bend in a graded manner, and that might be in non-threatening ways, such as pulling his knees to his chest while lying on his back, or bending, leaning forward and sitting with his hands on another chair so he feels safer to start with, for example. But if we can expose him to some relaxed bending, or even just getting breathing, belly breathing going to relax his trunk muscles, And if you get symptom relief with it, that gives us a pretty strong indication that those functional behaviours at the moment are unhelpful. So I've put pain behaviours in there as mentioned, so even shifting side to side and constantly changing position all the time when he's standing around, avoiding all those activities, relying on passive pain management to manage his symptoms would be examples of that. And clearly he's deconditioned. We could physically assess that to prove that as well, but just from his story, he's deconditioned because he's not doing any exercise. He does his work and basically rests beyond that. Any other comments or queries based on that?
Thanks, Tim and Su-Yin. I think it's interesting that Su-Yin brought up the facet that his beliefs seem somewhat conflicting, and I think it's not uncommon that, especially for patients with a huge impetus to work, being the sole breadwinner, we see contrasting behaviors at the workplace and outside the workplace. So Mr. Shanker at the workplace, he's an overdoer, and it seems like outside the workplace, he's very protective, he's fear avoidant, his fear of movement. So, and sometimes these beliefs can be so entrenched over the 5-10 years that they are chronic pain that it takes a lot to shift their beliefs. I think so that's where a multidisciplinary team comes into play. If everyone, the physiotherapist, the psychologist, and the physician, all can give him a consistent message, then there is a good chance that we can get him to change some of these beliefs.
Yeah, I completely agree with that. As I said, the bending one, for example, some of those ones you can change quite rapidly because they get an immediate change in symptoms. So that's a very powerful one, which is very different for us saying, oh, don't worry about it, your spine's strong, you'll be okay, we just need to get you moving. If they can have experienced that things can be changed positively, then it's less having to take us on face value and trust us, and they experience that. But in the aspects, as you mentioned, for example, the work behaviours around pushing too much and probably overdoing it, agreed. If everyone gives a consistent message, and we use this all the time around our reporting and communication to give a clear plan with the other healthcare practitioners so they know what's being told to the patient, and then hopefully people are on the same page and those messages are reinforced.
Tim, I'd just like to add in a little bit here and actually
Sure.
Going back a bit in terms of the communication, as you mentioned, consistency is one. How important is it then, in terms of the presentation of the physio or the health professional? We read about it in the journals, we know about it, but sometimes it doesn't really happen, especially when the time is very short and we have so much to go through. And I mentioned this before, I think in other sessions, and I like to quote Jerry Maguire, you had me at hello. So, that's that perfect entry to rapport building. And how important is this, and how would you actually do it?
I think it's probably the top first, second and third priority with every patient is the rapport building. We do a couple of things in our clinic where we have the patient fill out some simple questionnaires. One of them is around what they expect to get out of the session, which is helpful because if they're wanting pain relief, we know that. If they're wanting a diagnosis, we know that. If they're wanting an exercise plan, we know that. So that really helps us know, are they on the same page with what we think they need? So that's a really simple one. We always use the short form Ouroboros psychosocial screening questionnaire with every patient. And that is also a very powerful tool because I'm not trying to make judgments just based on my questions for me to say, look, I think stress is an issue, or your beliefs are unhelpful, or your mood's an issue. It's quite easy to say, I notice on the questionnaire here, you marked really high on this score around feeling tense or anxious. And then that opens a discussion point that they've indicated to start with. So often as health practitioners, we need to cover off on these different aspects, but we can get it wrong or get the approach to that wrong, which takes experience. But using something like that questionnaire, if you're not so experienced, is a really helpful guide that you're really just going through the patient with what they've marked as relevant or important. So that's one way of getting the rapport or not overstepping the boundaries early on. And the other way is just listening to their story for the first minute or two of the consult. So I'll usually start with, tell me your story or tell me about your problem. and I'll let them go for a minute or two. So at least they know they've been heard to start with, and then obviously you need to tailor the discussion from there, but that's how I would tend to approach that. Have you got other tips?
Yeah, I think what you have said is something that we do in sessions. I'm just going to add on here something that my supervisor actually mentioned to me before. And then in terms of experience, what I've realized with patients, it's not our job to convince patients that our treatment is what's good for them. And I think you highlighted that very clearly in that rapport that you mentioned. You ask them, you sit down with them and ask them what they really want. Because if it's our job to do that, it really is an ego thing. It's not our job to convince patients as well to accept our treatment. And that's where the psychoeducation can go wrong, or the education of patients can go wrong. And that is where it's a pride thing, right? It's a professional status. We are the profession, and sometimes we fall into that trap. And so it's also not our job to tell patients that that what they have been doing so far, is whether subtly or directly, is not correct, because then that is judgment, as Tim mentioned earlier. I think that's so powerful. So if we put away a little bit of our judgment, we put away a little bit of that ego, or put away a little bit of that pride, and we throw in a little bit of that gratitude and grow with the patient, we get a very nice picture of the patient in treatment at the end. So if you get what I'm saying, it's actually a JPEG.
Yeah, thanks, Su-Yin. I like that. I really like the term shared decision making, because at the end of the consult, it is about, here's some options, and the person needs to decide what's most relevant or important for them. And I find that quite liberating, because it takes pressure off of you having to give all the answers, and it's more about, here's what I think's going on, here's some possible options around it, and it actually makes your life a whole lot easier rather than more complicated when you need to feel like you need to be right all of the time, I think.
Yeah, and I agree. I think that's quite powerful if we can put it back to the patient, to ask what do they think, and then from there we can have more insight into their pain beliefs. We can also have more insight into what is affecting them. And oftentimes I find, Tim, what you said is really helpful if you sit down there and ask them what are their problems and how is the pain impacting them. That is a show of genuine concern, and they will be able to tell you where are their problems, and from there we can work through a shared treatment plan that is acceptable to the patient.
Yeah, great. So we'll keep moving on. I know we need to keep to time. So this is just a summary page, which really simply, this is, again, the app generates this, where in this instance, as I said, I would have this as a non-specific diagnosis. I wouldn't have specific diagnosis in there, and I'd explain that to the patient, but I wouldn't tell them they've got a non-specific diagnosis, because that is meaningless to a patient. I would say, you've got back and leg pain, and the reasons you've got back and leg pain are, and we'd go through that list. And particularly the contributing factors down the bottom here tells us these are the factors we've marked as high during the assessment, so our management needs to reflect that. So just moving on, this is just a quick reminder. Clinically, we test somatosensory sensitivity, so sensitivity on the skin, often using light touch, sharp and cold. And that can be really helpful both to identify the presence of increased sensitization, but it can be really helpful as a tool to show the patient, particularly when we're trying to convince them that we're not worried about pathology, but when they notice heightened sensitivity, it shows them there is still something wrong, but it gives you an avenue in to say, well, there's a whole range of things that can impact on your increased sensitivity, including your sleep, your mood, your activity levels, how you think about and approach your pain, whichever of those are relevant for the person. So that article is a clinical article which got scripts in and around how to go through this assessment, and there's also videos attached to that that demonstrate the assessment of that. So that might be something that you find clinically useful. So just quickly talking, so for Mr. Schenker, the management plan, number one is understand and take control. As I said, assessment is education. So if we could prove we could change his symptoms by getting him to relax and breathe and move with less protection, that's a good angle in. Doing assessment around pain sensitivity as well can be powerful to go, we can still see you're really sore and sensitive, but we've done the other examination to rule out pinched nerves and other pathology. So that gives us that opportunity to use the assessment as education, agree on the plan and goals. And with people that aren't so sure, we often use an activity and pain diary with them to say, well, here's the plan, but we really care about what happens with you. So we want you to track this and let us know how you respond. That can show you whether you're progressing well or not with this approach, but also tells us whether we need to modify what we're getting you to do. The cognitive side, from a physiotherapy perspective, as I said, we'll use those functional behaviour experiments, so movement experiments such as the forward bending, to see if we can prove that. In this instance, probably specific psychological support would be important, and cardiovascular exercise would be helpful for lots of reasons, including assisting with some of his mood factors. Lifestyle-wise, getting his routines more normal and appropriate rather than passive, and again, using the activity and pain diary to help him understand how important that is for him. Then specific exercise rehabilitation would be around general conditioning, but it would be based on function and meaningful movements and activities for him. And as I mentioned, again, the cardiovascular exercise would be important, and he's got a goal for running, and that might be appropriate. Obviously, we'd start with walking, but see how he responds. Socially, again, improving his routines around that. But if his pain management and understanding gets better, a lot of these things are likely to improve. And with the pain management, I'd be interested in Say Yang's opinion here around the medication review. He's on Lyrica. How helpful is it? Depends whether he's got significant, central nervous system sensitization, because it doesn't look like he's got other specific, radicular or sciatic nerve sensitivity necessarily. But the power of medical practitioners delivering a consistent message is also really important in this instance.
Yeah, thanks, Tim. I think in terms of his medication, the Lyrica may be helpful because he obviously has a fair degree of central sensitization. As you can tell from, he has a lot of pain, there's a lot of fear of movement. So the Lyrica could perhaps serve a role at reducing this central sensitization, but one needs to be cautious because one of the common side effects of Lyrica is weight gain, and we see that his BMI is already 30, so that would not be helpful for his chronic pain. So I will be cautious against going up on the doses. Sure. And of course, for the other medication, I think he seems to be using them fairly appropriately. So I think he's not overusing his tramadol. So I think as long as we can put in place a good exercise regime for him, we can take off some of his unhelpful pain beliefs, and I believe that the medication will help to facilitate him towards a more functional state.
Sure, very good, thank you. Su-Yin, did you want to add anything from your perspective?
Nothing specific at this point, Tim.
Okay.
All right. Okay, so
and
now, yeah. Okay, so what we're going to do now is we're going to have a Zoom poll while we have our question and answer session for this case study, okay? So if the audience can answer this question, in my clinical practice, I'm confident to differentiate between pain types. By that, we meant differentiating between nociceptive, neuropathic, nociplastic, as well as mixed pain types. If you could input your answer, and we'll give you 30 seconds here, we will tabulate the results, okay? Now, at this juncture, okay, while the audience are doing this, answering the question for this particular poll, there are a few questions on our chat right now. So the first question is this: given Mr. Schenker's presentation, could you just clarify the classification of pain type as nociceptive, particularly given the sensitivity that seems apparent? And would nociceptive plus nociplastic be considered mixed in this framework?
That's a nice curly question to start with. Thanks very much. We have discussed this a lot, particularly Helen Slater and myself, who's a co-author of the framework ebook. And in short, pain science and pain medicine still doesn't particularly agree around this. You can have nociceptive pain with increased sensitization that could cause his symptom presentation there. But you could also have the presence of nociplastic pain that explains his symptom presentation as well. But the definition around nociplastic pain is really the absence of being able to clarify it as nociceptive pain or neuropathic pain. So it becomes around I can't even say nomenclature, can't say the word. So it becomes around the terminology of that. But in the instance, if someone still has focal back pain, you have to assess this person where it was clearly localized to a level or a couple of levels, and then there was radiation of symptoms beyond that. It may be nociceptive pain with this increased sensitization. Alternately, if there was just broad, widespread sensitivity throughout the whole region, then you would lean that arguably more towards nociplastic pain. That would be our position on this at the moment. Others may wish to comment on
that. Thanks, Tim. Thanks, Lester, for the question. I think the term nociplastic was coined by IASP just a couple of years ago. In a patient like Mr. Shanker with an initial what seems to be like a nociceptive type of back pain, but that would persist and become chronic, and then with apparent element of central sensitization. I think it is a bit gray. One could classify it as a nociplastic or nociceptive. In the presence of initial nociceptive sources, like in Mr. Shanker's case, the facet and the spondylolisthesis, it is a bit more gray because we're not sure whether these original nociceptive sources are still generating the nociceptive pain. And as Tim alluded to, if the pain was more widespread, then perhaps it would qualify as a nociplastic or a mixed case, nociceptive with nociplastic.
And ultimately, we can get caught up on that. And more importantly, being aware of that increased sensitization and the lack of mechanical behavior of the symptoms, that alone becomes powerful to go, okay, we can remove our focus away from the pathology and look at the other different factors that are contributing to this person's ongoing pain. So even if there was discussion or disagreement around that, I think if we could agree on the contributing factors where the management focus needs to be, that would be important in this case.
Okay. All right. Now, what we'll do now is let us have a look at the results of the poll. So, hang on. Can everyone see the results right now? Yep. Okay, so 56 participants participated in this poll. So the majority stated that yes, I have some idea of the different pain types, and and a few of them, actually 19% and 5% stated that no, they have not heard of pain types and have no idea how to apply it in clinical practice, or like they have not heard of it prior to this webinar. Now, do our speakers have any suggestions of certain resources that the audience can access to learn about pain types then? Any of you?
There's a range of options. IASP website has certainly around the definitions and some different information there. The practical application of it, there's more information in the ebook, obviously, because I'm involved in that, so I'm going to make comment around that. But also within the ebook, there are references to other good reference sources around information around that.
Sure.
There is a recent article by Joe Nays in the Journal of Clinical Medicine 2021 about talking about the ISP criteria for nociplastic pain in musculoskeletal conditions. So I think one can look that up. It gives quite a neat summary about how if we classify as nociceptive pain, then it implies some form of tissue injury, and we focus on pathology targeted approaches like what Mr. Shanker went through in the earlier part of his pain journey, and then subsequently, if If it seems more of a central sensitization picture, more of a nociplastic pain picture, then we really need to anchor the patient on a broader multimodal approach so that the patient can go through pain education, greater activity, stress management, exercise therapy, sleep management, so on and so forth.
All right. Okay. Thank you for your responses. Now, just being cognizant of time, I'm just going to ask one more question. I thought this is actually a really relevant one. So it is with regards to, is this framework practical for daily clinical use? I reckon that it will take at least an hour to complete. And we have not even discussed management and treatment plan of the patient. Tim, your take on it?
Yeah, no, that's a good question. We originally developed it for use with students, so within the education component of that. But quite interestingly, independently from there, we've had people from all over the world contacting us and letting us know that they've been integrating it into their clinical practice. Hence, we developed the use of the app. If you're not familiar with it, absolutely it takes time. I use this model in my head every day with every patient. So obviously it gets easier over time. What we suggest to people, if they're starting out with it, they probably do need to put aside an hour a week with one patient to go through it, because it really will challenge your thinking and take time to get your head around it if that's not a familiar approach. And then from there, yes, it's integratable into clinical practice. For my private patients, I have 40 minutes with them. For longer complex review patients, I have an hour. And in that hour, we go through full questioning, full physical examination with them, plus education and delivery of a management plan. So it's very doable within an hour, even for the complex cases, but it takes time.
Sure. Thank you, Tim. Okay, I think we shall move on with the slides. So let's go on to case study 2 right now. Hang on, can I just stop the poll, please? How do I get this off the screen? Stop sharing. Okay. All right, just give me a moment. Can you all see my screen right now?
Yeah, Wendy, I can see, so I'll just dive right into the case vignettes 2.
Sure.
Okay, so case vignette is about someone with painful knees and how should the patient progress from there.
Mm-hmm. Okay.
Okay, so our patient is Miss Lim, 36 years old, a slim-built lady. She had bilateral knee pain that's affecting work and lifestyle for a year. Was initially told that she had osteoarthritis, and then upon having a second medical opinion, she was diagnosed with patellofemoral pain syndrome. Okay, so that's PFPS. She had 2 cesarean sections in the past and no other significant medical history. Upon examination, she had a normal gait but walked cautiously. She was wearing knee guards, which had to be removed for the examination. There was generalized tenderness detected over both her anterior knee and patella. There was some limitation of knee flexion. She could only flex up to 120 degrees. And there was a mild suprapatellar effusion. Patella grind test was positive, and provocation test did not reveal any ligament deficiencies. However, we were not able to perform the McMurray's test because she was in quite a fair bit of pain. So she describes the pain mainly in the anterior knee region, giving us a pain score of 5 to 8, and the pain is described as a constant, aching, throbbing type of pain. Investigations-wise, she had a knee x-ray a couple of years ago. It was normal. But because of the persistent pain, she had a MRI of the knees done just last year and did show some chondromalacia patella with a high riding patella. In terms of pain medication, Ms. Lim is using a tramadol 50 milligrams, which she uses about 1 to 2 times a day. And we also note that she's suffering from insomnia and requires diazepam, which she uses about every alternate day.
All right. Now, when asked about the aggravating factors, so Ms. Lim stated that going up and down the stairs really hurt, and this movement is important for her as she lives in a walk-up apartment. So squatting to attend to a 4-year-old child is unbearable, and walking for more than an hour when she needed to do house visits, as well as standing in her heels, can hurt her knees. So during the physio session, the physio asked her to demonstrate the way she squat to attend to a young child. So she did the squat movement very cautiously with a lot of fear, as shown in this picture. The physio then observes that she can sit to stand from a chair with ease, and hence casually asks if she can demonstrate how she sits on the ground. So despite having difficulty calf squatting, Ms. Lim was able to demonstrate a full squatting maneuver to get into the cross-legged sitting position and was able to stand up with relative ease. So now when asked what will relieve her pain, now in a joking demeanor, and yeah, she's really cheerful as she was, relating that, she mentions that time away from her children will probably help. And she reminisced that going for stuff like facial and massage, time with friends or away from work will help her. So when asked what was keeping her from this, she mentioned that her children were taking up a lot of her time, and there were lots of complex cases that she was handling at work in this pandemic. So there was just not enough time in her view. So her 24 hours behavior, there is knee pain and stiffness in the morning, and this resolves in about 10 minutes once she gets out to work. Her pain is pretty much activity dependent, and pain may increase throughout the workday, especially when managing complex cases. Now, she doesn't sleep very well at night, clocking at most 4 to 5 hours of sleep, but mentions that her sleep disturbances are not due to pain. So her current activity levels, she leads a sedentary lifestyle, tries to swim 1 time a week, attends online yoga classes when she has time, and walks her dog 3 times a week with her kids.
So Ms. Lim is a social worker. She has 2 children, 4 years old and 10 years old, and the older child has special needs. She's been separated from her husband for a period of time and currently going through the divorce proceedings. Her husband had an extramarital affair. She lives in a private property, a walk-up apartment on the 3rd story. In terms of her pain behaviors, she keeps up appearances at work, she socially isolates herself, and generally keeps herself busy to avoid thinking about her pain. She also takes PRN tramadol to dull the pain. So Ms. Lim always asks herself, why me? I need to be strong for my kids. I can't let this pain get me down. No pain, no gain. I just need to trudge through this pain. Maybe better to keep my suffering to myself. No one understands, and I really don't want any pity. In terms of her emotional state, Ms. Lim has anger outbursts at her children. She cries herself to sleep most nights. She generally catastrophizes and has occasional panic attacks. And this is her presentation. In terms of her treatment goals, she hopes to wean off pain medications, to walk up and down stairs, to squat with minimal difficulty, to build up her cardiovascular fitness levels, to return to her social self at work, and to stop being angry at everything. And Tim, over to you.
So again, I've marked specific or non-specific diagnosis here. On her radiology and her examination, she quite clearly has patellofemoral pain. Often it's discussed, well, that is a diagnosis, but is it a specific diagnosis that requires specific management? So if you've got a fractured leg, there's clearly specific management around that for the fracture to heal. With patellofemoral pain, that's contributed to a range of factors. And as we can hear from her story, this might be a range of a number of different factors contributing to Miss Lim's case. So it's chronic persistent, there's local knee pain, but given some of the other features around her symptoms, is likely nosoplastic pain. So this ties back into the discussion with the previous case. There's mixed mechanical and non-mechanical in that it is activity related, but again, it would depend on how much she specifically did. So for example, does 1 or 2 flights of stairs flare up for 5 minutes, or does that leave her sore for the whole day? And it sounds like there's a degree of sensitization there. But again, we would assess that specifically clinically as well to help judge the relevance of that or not. So similar to the first case, cognitive factors are clearly high around her beliefs around what's wrong, but she wasn't really clear, or we don't really know what she thinks is wrong. But certainly her approach to managing her pain, where she thinks she just needs to push through and get on with it. Again, there's mood factors there, and socially as well, around her social circumstances at home, being a single mum. The work considerations I've marked medium there, more around the social isolation concern rather than the work itself, but that would something that I'd be flagging as relevant. And that may need to be directly dealt with, or as her symptoms get better, that might also improve by itself, but we'd certainly need to track that. The lifestyle factors, they're medium, if not high, particularly given the comments around her sleep there, because that persistent poor sleep certainly can strongly contribute to her pain experience. And obviously her exercise levels, they're not terrible, but she's relatively sedentary there. And again, whole person in terms of general health or other factors, there wasn't a lot listed there as significant. Did anyone else want to comment on anything that I've marked or listed there?
Yeah, I think Tim, you've highlighted one important point affecting Ms. Lim, and that's the sleep disturbance. In the case, she's using diazepam for sleep, and that is quite unhelpful, because diazepam is a benzodiazepine, and there are problems with tolerance and addiction and dependency. So diazepam, the effect tends to wane with time, so it is not encouraged. So rather, I think as a first step, it is important for us to assess the patient's sleep hygiene to see if there are any important lifestyle changes that we can encourage the patient to make. And then if the patient still continues to have very disturbed sleep, then we could refer on to a physician or a psychiatrist for consideration of a less addictive pharmacotherapy, such as some of the Z drugs.
Yeah, I agreed. In the Australian context, we would certainly look at sleep hygiene here as a priority. And often, if there is increased pain sensitization and poor sleep, often even the GPs will trial people on something like amitriptyline or nortriptyline.
Yes, I agree. This is what I am inclined to do as well. The addition of tricyclic is helpful to improve sleep disturbance, and also its antineuropathic properties may help ameliorate some of the central sensitization. So in fact, I will switch Ms. Lim over from the benzodiazepine to a tricyclic.
Yeah. And then this case is like peeling back layers, because there's so many factors going on. You don't necessarily need to treat them all. Sometimes the sleep component might be only 5%, even though her sleep's poor. It might only be contributing 5% to her pain, or it might be 70%. So I've seen cases like this where, the medication changes and you improve their sleep hygiene, and suddenly they're saying, my knees aren't bothering me very much. So that's why each of these factors that we mark as medium or high would come under consideration. But that becomes the skilled judgment of which ones are the biggest priorities and we target first, because the danger is you throw all these treatments at people and they don't necessarily need all those elements treated, which makes dealing with these people quite interesting. Did you want to add anything to that, Su-Yin?
Yeah, I liked your comment about the work considerations, where you said mainly focusing on social isolation, and you kind of labeled it as rated it as medium. I think this is something that not many people will actually consider. And even if they did consider the isolation as a work component, maybe they will actually rate it as low rather than medium. So this is actually something that is important to highlight. In terms of what you mentioned just now, when patient does come to us, and sometimes we have the sense that we really need to solve all their problems because everything is important to them. So what you mentioned about, actually, if we go and dive a little bit deeper about sleep, maybe it's just 5%, and maybe that's not something we need to worry about so much. And then we can focus the attention on the right components and work with the patient. I think earlier you also mentioned with the other case that we actually sit down with the patient and ask them what's their expectation. I think listening to the patient's story here is more powerful than getting the job done in terms of our clinical assessment, full clinical assessment in that whole one sitting.
Yeah, I agree. And on top of that, where you talk about this social isolation at work, Wendy mentioned she jokingly said her easing strategies, most of them were distraction based. So the last thing she needs is to be hanging out by herself and thinking about her symptoms all the time or catastrophizing. So getting the routines right around that may be quite powerful for her. Okay, so the functional behaviours here, Wendy talked about that in terms of how she was showing how she would squat, whereas she was relatively untroubled getting out of a chair. So when we talked about behaviour experiments with the first case and functional movement experiments, we would use that squatting and sit to stand again as another powerful way of showing to the person, well, this hurts to squat. Let's get you getting up and down off the chair, and that's not as sore. They're actually very similar movements, and then breaking down what's the difference here. So how could we modify or change this? So that would be important. So that's the impairment of control of how she's moving. Again, there are certain pain behaviours around avoidance here that we would need to consider. And again, this deconditioning factor because of that avoidance. So all of those would potentially come into play in terms of management planning. So again, the summary there, the key things to focus on: the cognitive's high, the affective's high, the lifestyle is medium, possibly higher based on what we've heard tonight, particularly around the sleep. The social and work would be tougher to change, but we would keep them in mind as part of the considerations. The pain management, she's managing okay around that. As we said, the more concerns the medication for her sleep, and then the functional behaviours of how we're going to manage this patient. So what might that look like? So again, clarifying the diagnosis, because she'd had an osteoarthritis diagnosis as well as a patellofemoral pain diagnosis. So telling her what that means and what's the potential prognosis around that. So being clear there would be important. So yeah, there's a clear reason why your knees are sore, but people with those scan findings can return to the full levels of function that she aims to. So we've just got to get the right program in place and deal with these different factors that are potentially making her knees more sensitive than they should be. So agreeing on that plan and following the patient's preferences, as Su-Yin mentioned. And then the cognitive side, like I said, the behaviour experiments there, and trying to give her active coping strategies around rather than just need to rest or avoid. What other things can you do that you feel positive about that are actually also good for your legs? So catching up with friends or going for a walk with friends, for example, might be a simple option there. So the medication review, I'd put again, sometimes we might be trying to judge how effective is the tramadol or necessary is that. So we would refer them back to their medical practitioner to discuss that. And again, that the sleep medication is important. Again, the activity and pain diary could be helpful. It's, as I mentioned in the first case, around them understanding and taking control. That doesn't mean they have to spend hours and hours filling things out. You might just give them a targeted thing to consider. Okay, you've talked about the squatting, for example, as being a problem. If you modify that to how you're moving with your sit to stand, let's track, does that make your squatting movement more easily? Or if you're going for a walk with your kids, are you actually getting sore from that? If not, let's increase your activity level. So it just gives them ownership and control of understanding how to progress.
I'd just like to jump in here, Tim.
Yes.
Yeah, Tim, you mentioned about the medication and about empowering the patient with active coping strategies. So from my experience, those patients who are heavily reliant on pain medications, they are often passive copers. So
Yes.
it is good that if we it's good on the physician side, if we give them a regime of pain medication, we need to emphasize that is to facilitate them to cope actively, to facilitate their activities and their lifestyle. So that is important. Otherwise, some of them will continue to passively cope on pain medication. Yeah, back to you.
And that's, I think that's really important. And we've had discussions with a number of leading pain medicine physicians in WA around this topic and whose role is it to talk about medication, because it's certainly got to be careful around scope here. The discussions we've had with the pain medicine physicians in Australia is around, it's very appropriate from a physiotherapist perspective to talk around clinical guidelines and what we know is recommended for different types of conditions. For example, simple analgesics around osteoarthritis, for example. So we will often furnish them with guideline-based information, but then we'll always refer back to their treating medical practitioner, for example. And if that medical practitioner is aligned with clinical guidelines, it's just really powerful and helpful that they're getting a consistent message from multiple people, which just adds to the confidence that the plan that they've got in place is appropriate.
I just want to add in here as well in terms of
Sure.
the activity and pain diary that was mentioned for both Mr. Shankar and even for this Ms. Lim. I think that's something very powerful that we use in sessions. And on the psychological perspective, I do get patients then to add on record their thoughts. So what were you thinking at that point in time? What were you feeling at that point in time? And if they are not able to articulate, and I think it's maybe a bit more of an Asian culture, they actually get them to have emoticons or even colors of the faces. So red will kind of represent I'm really angry at this point, and maybe like blue, I'm actually calm and I'm relaxed. And when they do actually bring the diary in, is very interesting because you get to compare and contrast, and patients may not actually see that they have changed along the way or what might actually be the main trigger. And I think now some of the patients they're quite creative. They actually show me that they use e-calendar, and they can actually put all these on the diary. So through that, just at one glance, we're able to see and point out the patterns of pain and patterns of activity engagement. So that visual is actually something that is very helpful in interventions.
Yeah, agree. I think you raised a couple of good points there. There's different ways of expressing it and recording, and I've learned lots from different patients. They've come up with their own ways of how they would go about it. And not everyone engages with a diary or in the same way. So we also have to be flexible of what we're asking of people, because if they don't think it's useful or they're not engaging with it, it's possibly a waste of time. So different ways of doing that for different people, I think, is important to keep in mind. So there'll obviously be specific exercise rehabilitation, because we know the evidence around patellofemoral pain is for functional exercise, as well as specific leg strengthening and also broader cardiovascular exercise components, but the levels of that would be set at what her capacity and tolerance is. Mood side of things, again, there may be a role for specific psychological support here. And it depends on the context that you see this patient. In my context, sometimes we'll do a few sessions with a person and flag that mood is relevant. And if we start to give them pain control and their mood's automatically getting better, then they may not need specific psychological support. If it's not, then we'll then go back and say, well, here's the questionnaires that show this. This is something that seems quite relevant. Do you think you need some additional help or support around this? But that's in my context. If you work in a multidisciplinary pain clinic, it's much often easier to get a team involved more quickly. And again, around that, the social engagement at work would potentially be relevant, or it may just happen as her symptoms get better. So we could approach that from a couple of ways. Any other comments there?
In terms of the affective component for Ms. Lim, which is quite different from Mr. Shankar, so although both are rated high on cognitive and emotions, for Mr. Shankar, from the psychological perspective, again, I might actually focus more on the beliefs and trying to modify that. But with Ms. Lim, because of the EMA and the anger and crying to sleep, I may focus on the anger first, on the emotions, and then later on coming in with the cognitive aspect. So really building that rapport with her, and maybe female to female might be easier, and getting her to open up a little bit more. So the focus may not be on pain in the first session, but really what is the meaning of pain to her at that point in time. And I imagine if the rapport is good, she would probably start talking a little bit about her social environment, as well as the social stresses. And sometimes it's good to open up the conversation by talking about children. And she does have two that's also stressing her quite a bit.
Yeah, and that's your skill set there, clearly, and that's why we have a team involved in these cases. And as I say, it's very interesting, and I've seen this over the time, where the relevance of mood and psychological factors on pain is just very variable for different people. So some people will already have mental health support in place that because of pre-existing issues, which might be the case with this patient. And then they have the onset of symptoms, and then the mood stuff just really amplifies that symptom presentation, for example. And then in the odd occasion, they're quite different. If you can give them a diagnosis and some pain management control, then, you know, the pain side of the story can, you know, settle really quite quickly. So I think it's being open to both of those possibilities with each patient is what's most important. All right. Oh, did I click too far then? Sorry, Wendy.
That's all right. Okay, now we're just going to run a second Zoom poll while we have our question and answer session for this particular case study. So if the audience can answer this question, now in my clinical practice, I'm comfortable to ask people about psychological, social, and lifestyle factors. Yes, no, or depends, okay? Yeah, and for those of you who type depends, we'll appreciate if anyone in the audience can elaborate what are some examples or some kind of clinical scenarios that makes it really challenging to ask people about such factors. So it's either you can type it in a chat box or you may raise your hand to speak, okay? Now here, I do have two questions for team. So the first question being, with regards to the questionnaire which team mentioned earlier, are the questions open-ended or choices provided? If the choices are provided, will it come across as too leading? Yeah, I'm not certain which questionnaire this particular person is asking, but I would think that you mentioned Oribro. Yeah.
I don't know if that was around the initial, was that a question asked earlier, Wendy?
Yeah, I think so. That's right.
Yeah, that might have been around the individual's perspective, where I put a list of those questions up on the screen. Most of those, when you're trying to listen to someone's story, are very open-ended. So it's just a prompt to allow them to start talking about their problem or what their main concern is, or the story that they see relevant, because some patients might end up describing, oh, I did this injury to my knee, and they really talk about this bad injury, but when you question them a bit more, there actually was no specific injury. Their knee just started to get sore. So understanding that they believe there's been a serious injury means to me, we need to assess this properly to reassure them that there's no significant structural damage, for example. So those questions will be open-ended. The short form Oribro, they're itemised questionnaires where people score a number against, so they're not open-ended.
Okay. All right. Now, there is a second question here. So drawing the connection, connecting the dots between all factors highlighted would be very helpful, especially when you mentioned that maybe just by treating sleep, pain sensitivity would already improve tremendously. Would the app be upgraded to display such a mind map so that at one glance, the physio and patient can see this visually?
Good question. There's a couple of good comments or parts to that. In terms of treating one area, yes, that can have a big change. And it's important to remember that pain sensitivity is impacted by a whole range of different factors. Pain sensitivity is impacted by pathology. So some people will be highly sensitized because there is focal pathology there, which drives sensitivity, because increased sensitivity in the acute injury phase is a normal tissue response, and it's helpful to protect tissues. But then later on, sleep, mood, levels of activity, immune factors, general levels of health, all of those things can impact on sensitivity. So just because someone's pain sensitive, it doesn't mean they've got a psychosocial problem, for example. It just tells us that something is driving the system to be more sensitive, and that's where we can put our investigators cap on and try and help the person work out what are the dominant factors for them. In terms of upgrading and working with the map, with the app, in terms of where we go with that, very open to suggestions and ideas. We're working with someone at the moment around whether we almost use AI to help draw in bits of information about someone to help develop and evolve what that picture might look like. So I think those concepts are really good, and I think that's a direction where we've talked about creating something that we don't want to make ourselves too obsolete, but the patient can almost work with themselves to try and develop and evolve their own story, so they are perhaps fairly effective at coming up with what the main driving factors are, because to be honest, really that's what we're doing, aren't we? We're facilitating them to give us the information to work out what the problem is, and often they give us the answers. So I think there's a lot of work that could be done in that space.
Right. Okay. And there is a third question here. So based on Miss Lim's condition, what would you tell her if she asks, how long will it take for me to get better?
That's where I bring out my brilliant line, it depends. That's a very safe answer. But importantly, I think you do need to give timeframes. And the timeframes might not be to get better. I'll often answer this, particularly if someone's got a long-term problem that's been around for a while and they're not making any progress. I might say, for example, if we think sleep's the biggest issue, if we work with your doctor and the medication can be changed and we get good sleep hygiene going, if sleep's one of the main factors, I'd be expecting within the next few weeks, you'll notice some clear improvement in your symptoms, for example. The other side of it is, if I'm setting an exercise target around this, I will also set timeframes of within the next 6 weeks. If we're consistent with this program, you won't be fixed, but you should be clearly better. So you should be 20, 30, 40% better in terms of pain or function in that time frame. So I think we need to be accountable for timeframes, both for the patient to engage in something, because we can't ask them to commit to something forever, but we also need to be accountable to ourselves to go, right, we've set a plan, we've put a time frame on it. If it's not working, then we need to review. Maybe are there other factors that are more important than the ones we've chosen to focus on to start with? Anyone else want to comment on those?
Yeah, just wanted to add on to that. And I think I would probably get the patient to define what better means, because then that's the meaning of the pain as well. And then the conversation about goal setting can come in quite clearly. And through that, we can give timeframes, as Tim has mentioned. And then based on the goals, whether it's a physical goal, whether it's a lifestyle goal, we are able to then help patient to set the different short term. Usually I ask them what is some within the next month, if you're comfortable to come back, what do you hope to achieve by then? And that's just work with a SMART goal for that. And if they are not so realistic, I'll try and modify that. And then I'll ask them as well, then what's your midterm goal and what's your long-term goal? And through that, be able to maintain a conversation and the interventions that will help them to develop their own treatment plan and take responsibility for it.
Agreed.
Yes, I agree with Su-Yin and Tim. I think it is important to set some goals for the patient so that the patient doesn't feel like he's lost in the whole system. So definitely short-term goals in terms of sleep hygiene, some physical exercise and physical therapy. I usually set a goal about a month or two for the patient to achieve some targets. Of course, these targets must be aligned with what the patient wants. So it's usually a form of a shared target setting. And I think in terms of short-term goals, 1 to 2 months is a fairly reasonable period. And then as we get to know the patient better after several consults, then we can start looking at midterm goals. And that's when we may be able to push the patient to do a bit more over the next 1 to 2 years.
All right, now I guess we have a really nice comment here from one of our physician colleagues. So I guess this framework would be very useful if it can be shared among the physician, psychologists, physiotherapists, etc., who are looking after the same patient. This would align the objectives of the team and the patient. Yeah. Any comments there?
Yeah,
that's
it's a very nice comment, and I agree. There's options around this. One of the reasons behind the framework was to create a consistent language and have different health practitioners using the same terminology, because it's very confusing both for patients and health practitioners around this. So at a base level, if people were using consistent terminology, that would be helpful. But certainly using more specific aspects of the framework, even to do that problem list or the contributing factor list, might be a helpful way of sharing what the priorities or the goals are across the different health practitioners.
all right. Now, I'm just going to quickly share the results of the poll just now. So if all of you can see here, can all of you see the answer to the poll? The results of the poll? Yeah. So 73% answered yes, they are comfortable to be asking about all these psychological, social, and lifestyle factors, and 27% stated depends. So, well, sounds good actually. That means our colleagues here, majority of them are quite comfortable to be doing this. Possibly just one final question, and like any of the speakers can choose to answer this. So, like sometimes the psychosocial features in the MCTF can be really challenging to solicit from patients. So, like taking into account that clinical consultations are usually time contingent, are there tools or strategies that can help with it?
I guess I'll start the ball rolling. It's my area. I would say, we want to see the person behind the pain. I think that is sometimes something that we miss, especially in a busy clinic. We see the condition first before we see the patient, and we might then end up labeling the patient and not treating the pain properly. Then next is really to validate, and for them to see a psychologist, I will have to validate that they are not mad, that they're not crazy. Sometimes I get caught in a situation where they do have prehistory of trauma, and they have been in treatment for a long time, and then I go, oops, okay, I then have to change the language a little bit, because then what am I actually telling them? Next is acknowledging that all pain is real, and really there's no such thing as pain that is not real. Then I also would probably differentiate what is psychosomatic and why they're actually seeing me for, why they're seeing us pain physician, and why they're seeing a physiotherapist. Because if they are mad and if the pain is not real, they don't really need medication for that, or pain medications for it. And sometimes that's a buy-in. So in terms of practice in Dr. Ong Say Yang, it's quite interesting. We actually ask patients to rate the clinician interaction or psychologist interaction at the first session and the second session. And this is the STAR P, which is the survey of the therapeutic relationship. So the patients that rate me high on it actually rate me high on being stern as well. My psychologist is stern with me, and then they rate me really high, and I look at it and like, Or sometimes they ask me, you are stern with me, right? Yes, you are. But then they'll give me a comment and say, Dr. Yang actually listened to me. She spent the time. She helped me to clarify a lot of the beliefs that I had. And I think spending time with the patient, listening to their story, what Tim has already mentioned earlier on, getting them to move towards that meaning of pain, and really showing the patient that you're on their side. They are not just another queue number. They are not just another person that we want to treat and get better, like a factory line, but really we're interested in them and them only. And the interesting thing I would just want to add on here is, if they come with a caregiver, we do also need to validate the caregiver and support the caregiver. This is quite powerful, because you don't know what the relationship is like, and whether that is actually perpetuating some of the pain behaviors. So I will always address the caregiver, ask them for their name, thank them for their involvement in patient care, and also get patient to acknowledge. So in that subtle way, you kind of bring the patient and the caregiver together, so they are working together with you towards a common goal. And I think that helps to elicit some of the more of the psychosocial aspects, or building rapport, so that the next time that they come, and I always ask them, I don't assume that they'll come back to see me, even though I might get high ratings. I'll say, if you're comfortable to come back, this is what I'm going to do with you, and get their buy-in from there. Yeah, that's my take.
In short, I think validation and acknowledgement is really important. Yes, Tim, you have something to say?
I completely agree with what was said there. And as I mentioned earlier, as physiotherapists, we're lucky because we can put our hands on people as well. And that's where we validate people, by going through the test. So we've listened to their story, let's check this out and have a look as well. And once we take that approach to people, obviously the assessment will vary depending on their problems. I hope no one leaves with the thought that I'm telling them their pain's in their head or it's not real, but we manage that by really what we've described throughout here tonight, I think.
Yeah, I agree. And I think time is important. So in my practice, I do spend a bit more time for the first visit, the first time that the patient comes to consult me. And I think a powerful question is just simply to ask, in what ways is the pain impacting your life? And from there, you can pick up clues about the patient's pain beliefs or psychosocial environment. So I always believe that that is an important opening question to ask.
Okay. All right. Thank you to all our speakers. Now, so now we have come to the end of the webinar session. Okay. So we actually ran a little bit over time. So these are the email contacts of all our speakers here. So once again, thank you, team, for graciously taking time to share your knowledge here. And thank you, Say Yang and Su-Yin as well. I thoroughly enjoyed moderating this event. So to the audience, we hope you have taken away some of these learning points and find it applicable and useful in your clinical practice. Lastly, we'll appreciate if everyone in the audience can take some time to scan this QR code and give us some feedback for the webinar. So the Pain Association of Singapore aims to host good quality webinar, and your feedback can help us improve. So thank you for your attendance, and we wish you a pleasant evening.
Thanks, everyone.
Thank you.
Thank you.